So we're very lucky. We have a preeminent endocrinologist here. And I think most people probably 3, 4, 5 years ago didn't know what an endocrinologist was, but thanks to the weight loss drugs and obesity epidemic, now do. But I'll let him speak to that. He is somebody that we actually trust a lot of our Baker Health members with for his specialty. So that should tell you what we think of him. And he has an illustrious background. And these days, when you think about endocrinology, whether it's obesity, diabetes, thyroid, there's a lot that goes on. There certainly isn't any family that doesn't have somebody that struggles with this. And there's actually probably between all the endocrinopathies that exist, you're probably talking like 1 out of 3. I'm sure you're going to correct me, but no less than 1 out of 3 Americans. You're talking about pre-diabetic, diabetic, obese, thyroid dysfunction, what have you. And so tonight, this will be an episode, I think, that's going to be extremely informative. You as a doctor know this, and I find patients get disheartened and disturbed when I say this to them sometimes. Unfortunately, we know much less than we know. Every patient still passes, right? We haven't stopped that from happening. Almost everybody lives long enough to have disease and so on. And actually, unfortunately, in many areas, we're getting worse. We're getting worse, right? And so when you consider that, since we're getting so much not right, I think it's worthwhile every now and again to look at, like, lift our gaze and look around, and with a lot of humility. Some things we're good at, like when someone has pneumonia, like I don't need to debate you on it. Like we're pretty good at fixing that. Meningitis, but that's when I started. When I came out, that's what we used to deal with, like spinal taps. Ask me the last time I did a spinal tap, right? Now, but when I came out, if I made a developmental pediatric referral for autism once a month, if I did that, the office would stop. They'd be like, "What? What's this?" Now we make more referrals like that than all the asthma and stuff that I came up on. And so that's the premise. And so I think your specialty is something that is going to cover a lot.
Yeah.
So if you don't mind, just your journey, Dr. Agarwal, like how where you came from, where your academic and professional journey, and then what you do now, and then we could get into some questions.
Awesome. So first of all, thank you again for the invitation. I really appreciate this opportunity, and it's a pleasure to get referrals from Baker Health and take care of patients together. So I'm an adult endocrinologist. So I currently work with Summit Medical Group, Summit Health in Fair Lawn, New Jersey. And prior to that, I was at Mount Sinai in New York for 5 years as an attending. Going back to my background, I did medical school at Yale, and then after that, I was at Penn for both residency and fellowship. And then my first job out of fellowship was Sinai. And after 5 years, I decided to transition, from academic medicine to private practice to really focus, most of my time, all of my time, really on clinical medicine, taking care of patients. And within endocrinology, I see everything. So as Dr. Baker said, recently, a lot of my practice is actually weight management, almost probably 20 to 30% right now. Then we have diabetes, all forms, type 1, type 2, a lot of thyroid disease, thyroid nodules, which worry people a lot. Calcium disorders, osteoporosis, which really affects quality of life if you have a hip fracture or any other fracture. Adrenal disorders, pituitary hormone conditions. So really, that's a pretty wide variety of, types of things we see on a daily basis.
Great. Excellent. And so with that, should we start down the path to some questions?
Yeah, let's start. So question we had, someone asked, for folks who crave sweets, is there a difference between stevia, Splenda, sugar, etc.?
So that's a very good question, because that comes up a lot. So one thing we know for sure, that simple sugar will definitely raise your blood sugar. And obviously the carbohydrate load will eventually lead to potential glucose concerns and definitely weight gain. With regards to stevia versus Splenda versus Equal, a lot of these are, aspartame-based products. There's also monk fruit, which has become very popular recently. So these supplements or artificial sweeteners, we don't have a lot of information. Every couple of years, new information comes out about cardiovascular risks or benefits. What we do know from the day-to-day standpoint, it's not going to raise your blood sugar to the degree for a diabetic that it might be concerning. It's also not carbohydrate, so it's not going to cause as much of an impact on weight gain. So it's a good option for somebody who's craving sweets but doesn't want to take pure sugar. But the future risks associated with these are still unclear. And I tell that to all my patients. I don't want them to think that I'm supporting diet drinks every day and not regular soda, because who knows what the future holds with these artificial sweeteners.
It's good practical advice.
Yeah. Next question. Someone asked, what are the most common signs and symptoms of PCOS?
Yeah, so that's actually another something that I see a lot in my new practice. And this is a diagnosis, I think, that is overly done. And that's one of my biggest questions when I ask a patient who walks into my office. Just today I had two. I have PCOS. So I go back, let's just stop right there. How were you diagnosed with PCOS? If it was in your teenage years, well, periods can be very irregular, during that time. So that is not a good time, to really diagnose with PCOS. Then I like to find out, exactly what were the context that made the diagnosis. So somebody tells me, okay, so tell me about your menstrual history. So irregular periods, that's the number one, factor that would prompt me to think about PCOS. And irregular, I like the patient to define, what is irregular?
Yeah.
Just the cycle being late 1 week, early 1 week, or the bleeding is too heavy. And that's not necessarily the PCOS type of irregular periods that we're thinking about. And lately, a research way to ask that question is, in the last 12 months, how many periods did you have?
Right.
If you had fewer than 8 periods, then that's really, some irregularity going on. So that's your first criteria. The second criteria is, do you have some form of hyperandrogenism? So this is where, some, male pattern hair, that's the best way to think about it. So do you have like excessive chin hair, upper lip hair, upper arm, middle of the breast, umbilicus? Just generally, you feel that you are more hairy than another female
acne
individual.
falls in that.
Acne as well, so cystic acne, hormonal acne, as is often diagnosed, that definitely falls into it. So clinically, I ask that question, and then biochemically, I verify that, by checking their male hormone levels, so specifically testosterone. I also check an adrenal androgen called DHEAS. So that's your second criteria. Do you have clinical or biochemical hyperandrogenism? And the third criteria, which I think is generally the least important now, is the presence of polycystic ovaries.
Right.
And having like 1 or 2 cysts is not significant. It's really like 10 to 12 follicles or cysts on each ovary. And that's how you have your 3 criteria. And you really have to meet 2 out of 3. Irregular menses, hyperandrogenism, and the polycystic structural ovary structure.
And that's, you're right. I see, it's one of those things. It's like, it's on, I know we're talking about endocrinology this evening, but it's like on the infectious disease side, how people come in and tell me they have Lyme.
Yeah.
I'm like trying to get pinned down. Just before we leave PCOS, because you're right, I'll get like 16-year-old, 17-year-old young ladies where when they come in for that, the parents have infused that. Usually the mom has infused that, typically because she's had it or she thinks she has it. And so actually it's not a 2 to 3 times a month, I'll have a 15, 16, 17-year-old girl who comes in. Typically, she's a little overweight, and like had a couple of irregular periods. And then when you pin them down, like, and you do some blood work, the FSH, the DH,
Right.
the whole thing, and you're probably better at interpreting that, because even those hormone tests are a little, when they're young, it's not crystal, like it's hard to pin down just how abnormal or not.
Right.
Like I have one of my closest friends in training became a pediatric endocrinologist, and so I'll bounce it off of him often. And the question I have for you is, let's say clinically you suspect it.
Yeah.
Right. What are we're talking metformin, right? We're talking oral contraceptive.
Sure.
You want to talk a little bit about the ideal management, because I see just as much variation in management as I do in diagnosis.
Right. So the first line treatment really is some form of hormonal contraceptive, whether it's the birth control pill or even an IUD, because the idea is we want the irregular cycles to become regular, because we don't want you to just have estrogen in your system without any bleeding happening. Then that's the risk of uterine damage, endometrial damage long term. So that's first line. If you have, so let's say you do not want to be on a contraceptive because you're trying to get pregnant, then metformin is the next best option. And then if you're really deep into the journey of actively trying pregnancy, then the reproductive endocrinologists offer letrozole or Clomid, some older drugs.
Mm-hmm.
If you have the male pattern hair issue, there's a testosterone blocker, spironolactone.
Right.
We use that for acne.
Yep.
We use that for hair loss, abnormal hair growth. So that's a very common drug that I prescribe as well. But that's the constellation of drugs that I use. And one very common misconception with PCOS is that you're not very fertile. It's actually the opposite. All that extra eggs, the follicles, the cysts, are extra eggs that are sitting there. But the reason that it is hard to become pregnant is your cycles are not regular.
Right.
So you are actually a very fertile woman who has PCOS. It's just a matter of getting those cycles regular, and then you can get pregnant tomorrow.
Oh, that's interesting. That's good to know.
Someone asked, how can I manage my blood sugar throughout my menstrual cycle?
So that's another thing that we see a lot, especially in type 1 diabetes. As patients are on pump and we realize, oh my God, they have like a 20 to 50% higher insulin need during the menstrual period. And the reason that happens, first of all, is because progesterone it causes a lot more insulin resistance. So even if you're not obese and lean, which many type 1 patients are, you just have a difficulty managing it. And the only way to really manage it is, if you're on insulin, you're going to need more insulin. So if it's somebody on a pump or on regular doses of insulin, it's just okay to just proactively expect you'll need 20 to 50% more. And the same thing happens, during pregnancy. Patients end up becoming more insulin resistant, and they need a lot more insulin, during the course of the pregnancy. If you're not on insulin and you're a type 2 patient on just tablets, it depends on how bad things get. Temporarily, there are some drugs we can give you for that week. But if the numbers are only marginally off, you might be better off just monitoring your diet, being extra low carb during that time frame. Because I would hate to just, double or triple medications or add tablets just for a week or so, unless it becomes a chronic issue where your overall diabetes numbers are just going through the roof.
Right.
Nice. Next question we have, someone asked, any promising news for type 1 diabetics, and why is it predominantly in kids?
All right. So type 1 diabetes, there's a lot of promise happening for sure. So in terms of cure, we're still not there yet, but there's a lot of islet cell transplant therapy, which is becoming, I think it's almost nearly FDA approved, to do it. It's still in a research protocol at most institutions. NYU, I think, has one. In New York, there's a couple of programs. I'm sure Jersey has a couple as well. So that's, currently it's used only for somebody with, frequent hypoglycemia, or if somebody also needs, let's say, a kidney transplant, they go in and just do a dual, transplant. So that's definitely there. Pancreatic transplants are there. Now we do have immunotherapy that was approved, I think, in the last 2 years to reduce the risk of progression to full-blown type 1 diabetes. The idea is, type 1 diabetes, question also being, why does it happen more in children? It is an autoimmune process. So you have like 4 or 5 known antibodies that we can check for. Those, if they're present, the likelihood of developing type 1 is high. But exactly when it might happen, hard to say, because eventually the autoimmune system is going to kill off pancreatic islet cells, which make insulin. Then you're insulin deficient and you become type 1. The timing is hard to know for sure. But now we have therapy that is approved, FDA approved. It's an infusion, I think, every month for a few months that can curb you just at the antibody stage. So you don't develop further antibodies and you do not have full insulin deficiency. So it delays your progression. So it buys you a few more years potentially, but not complete cure yet.
Nice. Someone asked, are carbs really that bad?
So this is like, I think I have this conversation 5 days a week, 5 times a day, because I do a lot of weight management. And then my philosophy is a low carb diet, in terms of what to do. And carbs are really bad. And in patients who are on continuous glucose monitors, which a lot of people are, you can easily tell. So you can get objective data that you have a carb heavy meal and what your sugar is before and after.
Yeah.
And the biggest surprise as I have these conversations is patients don't realize how many carbs they're getting.
Yeah.
The amount of times the patient comes to me that, hey, I don't eat, but I'm obese. Right. And check my hormones, something is wrong.
Right.
And I've been telling patients lately, scientifically that is not possible.
Right.
We cannot create matter.
Yep.
The food has to be the source of the fat. Sure, you might have a hormonal issue making you eat more, but you still have to eat, to get to the carbs that will become, fat and weight.
Yeah.
So carbs, some of the neglected sources of carbs actually can be fruit. I tell that a lot. Fruit is nature's dessert.
Yeah.
Before we had cakes and pastries,
Yeah.
fruit was our dessert.
Yeah.
And like a banana, which everybody thinks potassium in bananas is it's 27 carbs.
Yeah.
So these things can really add up because and other sources of sugary drinks, bread, pasta, rice. We think of creamers and coffee.
Yeah.
A tablespoon is 6 carbs. As I talk to patients. Even bread, there's a lot of thought that if I'm having whole grain versus whole wheat versus white, I'm like, it's 5% better.
Right.
You really have to, rice is rice at the end of the day. Brown rice
Right.
versus white rice versus jasmine versus basmati, and same thing with bread. Bread is bread. So unless something is very high fiber, which negates some of your carbs, the net carbs are total carbs minus dietary fiber. That's how you calculate it. Just as you're picking at which food you want to take, that's what you want to focus on, those net carbs. And we know for sure, having on a high carb diet, it will be harder to lose weight.
Yeah.
Interesting.
Excellent.
Interesting. Someone wants to know what metabolic syndrome is.
So that's another, very common thing. So metabolic syndrome, I think there's 5 criteria. One of them is elevated triglycerides, which is something we check with cholesterol. Having, maybe insulin resistance, potentially pre-diabetes or diabetes. Being obese, I think the waist circumference has to be above a certain amount. And then potentially hypertension, also goes with that. I can think of those on the top of my head right now.
Yeah.
But metabolic syndrome generally is that because of your weight, generally overweight or obese, you have developed insulin resistance and fatty liver sometimes, and that causing, dysfunction in terms of your glucose metabolism, your cholesterol management, all of those things. And it's a term we throw around a lot. Sometimes people think it's like slow metabolism going on. I need to speed up my metabolism. But it's really, officially the syndrome that is really, I think, the biggest symptom is really insulin resistance, which happens because of just extra weight.
Yeah. And basically, it's like when the doctor, like we can't say you're officially, diabetic or whatever, but it's the precipice, right? Because we throw around pre-diabetic a lot, and that's more subjective than it sounds. And so, because you get those reports, and these days, you probably, I don't know if you deal with this. If you I take care of a lot of doctors, and so how many times a day, like someone's contacting us because they got the blood work before I did that I ordered, and so the guy's like, they're like, Z, they're freaking out because they think their 6-year-old has diabetes. I'm like, what? And I'm like, just give me the lab. They're on the phone. I'm like, let me see the labs so I know what I'm talking about. I get the labs, and the A1C is like 5.7, right? And if you're an ENT, you see like, okay, it says pre-diabetes, whatever, and you're like, well, yeah, no, it's like blah blah blah. And even the cholesterol, like you get these lipid panels on kids, and you'll get like a total cholesterol like 180, 170. You want it like below 150 in kids, whatever. And then you'll get triglycerides that are like whatever, LDL of 140. And the parents come in, and a lot of these kids are not obese. Like they're very well appearing kids. They're active. Sure, they have like Chick-fil-A more than they should, but the parents are freaking out. I explained there's a huge genetic component to this, right? And so, I don't know what you see, but what I like the smartest literature I come across is basically like every few years we find out it's like a little more genetic. Like now it's up to like 2/3 genetic. I mean, so you're like, well, a third is huge and can make all the difference, but there's explanations for why, but dairies and so on. So yeah, I think the metabolic syndrome thing, like many, many, many things in healthcare, doctors love to talk. Like we love to like say stuff, right? And explain stuff. And I think, I don't want to say it's unnecessary. I say we overcomplicate it. Like if you listen to what Dr. Agarwal said, basically like if you're gaining weight and your blood pressure is going up, think about what's happening before you get in trouble. That's what that's really what we're saying here, right? So yeah.
Nice. I think this is like the question of the night. Someone asked, what are your thoughts on GLP-1 agents, weight loss shots, and meds? And then also, what is your rule of thumb for patients who want to stay on these medications when they don't really need them?
Okay, so very, very valid question, and it is the question of the day. And a half our time is spent figuring out which pharmacy has the GLP-1.
Probably question of the year.
So GLP-1 therapy, and now we have a dual GLP-1 GIP, which is the latest one. That's the Manjaro for diabetic, and the brand name is Zepbound, for obesity patient. And then commonly, in the social media, you hear about Ozempic. That's the most famous one, and then Wegovy is the obesity version of Ozempic. So these drugs are great. First of all, from a safety standpoint, these drugs or class of drugs, starting from the daily injections, has been out for more than 15 years. So we know there is long-term safety with this. Now that the drugs are being used at a much higher volume, you hear case reports of all kinds of stuff. Colonoscopy prep not happening fully. Pancreatitis. Gallbladder issues. I had a patient with that. So those volume of issues have gone up, but I would say the drugs are still the safest options we have when we're trying to do medical therapy, whether for weight management or diabetes, to help you lose weight and control your overall health. So within these drugs, so I prescribe them very routinely. We always like to start with the lowest dose. We gradually titrate them up depending on how the patient is tolerating it. And if somebody is losing weight on the lowest dose, there's no requirement to go on the higher doses. You can just stay on the lowest tolerated beneficial dose. And we're talking about, good 15% weight loss. And I've definitely seen that. And some patients lose weight on the lowest doses. In terms of, going on maintenance, for these drugs. So that's a question that comes up. And my answer has become very, very, very concise on that. I strongly believe that if behavior is not changing, then yes, you're going to be stuck on these drugs forever. But at some point, you might have insurance issues, cost issues, you cannot find the drug, and then what are you going to do? So you might have a few weeks that you're without the drug, and then you're going to really struggle. And I use the same example of bariatric surgery. Lots of patients have gone through a full gastric bypass or a sleeve gastrectomy, and they have regained the weight because the behavior did not change. And the behavior that I'm pointing out to is, portion control, reducing carbohydrates, and really focusing on what healthy foods you can eat, so you're not dependent necessarily on the chemical to do it for you. And you can kind of just get used to it over a span of, let's say, 12 months at minimum. I'm very comfortable giving them for 1 year for obesity, and then I've done longer, obviously. But if I really feel that behavior is not changing, then I tell the patient that, yes, you're going to be miserable, when you stop it. And that goes with any of the tablet options as well. So right now, we only have one FDA-approved tablet when it comes to GLP-1s. It's called Rybelsus. It's the same chemical as Ozempic and Wegovy. But there are some more on the pipeline that are coming out. And every few weeks you hear something about some pharma company came up with something. And that is the next holy grail, I guess, to have like a daily tablet or even a weekly tablet. But the injections are easy to use, so nobody has really a barrier, that the injection is the bottleneck that they just cannot get over. So I tell my patients I'm mentally not there yet to using these long term for maintenance. But now that I'm using them so much, I'll have to know in another year or so how many of my patients are really able to come off of it.
Yeah. This is been pretty revolutionary because, the medicines in general are just a funny subject, right? I'm not the biggest fan of pharmaceuticals, but one great quote, I think it was the founder of Eli Lilly. I don't know if he had a biography, I forget where I read it, but he had a quote once that anything that doesn't have a side effect by definition is not a medicine. If it can't hurt you, it can't help you, and you're wasting your time. And actually that's true, right? Because then that's the placebos and blah, blah, blah. And so, no doctor wants to use medicine, but we use medicine every day because you're balancing against, and so many of the parents I see, because, I take care of their kids, but you see the parents all the time. And, the beautiful thing about about being a pediatrician, if my brother takes care of a parent, the kids don't really have a relationship with him necessarily until they're geriatrics.
Sure.
That's different. If he has a 43-year-old male that comes to see him or whatever, or female, that's it. As the pediatrician, you have like a very intimate relationship with the family, right? And obviously the kid is your patient, but the parents are trusting you with the single most important thing in their life, actually more than their health. They value their kid's health more than their own health. And so you know everything about them. Like they tell you, and they, by the way, they come to you as a pediatrician for third and fourth opinions, like all the time about themselves, right? I mean, like, I don't know, 1 out of 3 visits, there's some comment on mom or dad's health. Like they're like, well, Z, you know, I went like this. I have a great scapegoat because I'm always like, just go to my brother. Like, so, or I'll just literally, I'll FaceTime if I don't know. I'm like, you know, but I've seen so many families that come in and let's say the kid's 14 years old and I was there for the delivery. Like I'm thinking of these families as I speak, and I know the mom or the dad like struggled with weight for like 14 years. I've known them. Like since mom had the kid, can't gain 30 pounds, can't lose it. And so many are coming in now. Not only like, you know, we talk about the weight loss and the cost to the healthcare system and the diabetes and this, that, but you know what I see is they change as a person, like their confidence, their happiness improves. And so as long as I think we always lead with medicine's bad and only use it if you have to, as long as you lead with that, you can't be extreme. You can't be closed-minded. You need to be, you know, it's had such an incredible impact on so many people. Now I know like Iad and his team, we've had people at Baker Health who get pancreatitis, who get the gallstone stuff, more than a few, like we've seen it. But like you said, out of, you know, you're talking about like a fraction of whatever. And that's why you start at a low dose. And that's why, you know, sometimes the members will get, I shouldn't say, sometimes they're like, why do I have to come in to get checked again? I've been on it for 2 months or whatever with no problem. And I'm losing weight and I feel great. And we're like, great. We just need to get our hands on you and make sure like blah, blah, blah. Or like, or you could ask as long as they're patient to have the conversation. But I think, you know, what I wonder is where is this going? Like I'm fascinated. I have a guy that I trained with, who's like great guy. We came up together and our practice uses him, and there's like 7 of them for bariatrics.
Sure.
And I take care of his family.
Yeah.
And he's like great guy. So he talks very openly. He's like, Z, man, I gotta, are you hiring primary care? I'm like, he's like, well, I'm going to be out of a job soon. He's like, the cases like literally he started telling me details about how much the cases have dried up. Right. And that's like an immediate secondary effect, but like tertiary and quaternary effects. Like if all of a sudden this happens, like MIs, like diabetic insulin resistant cardiovascular disease, podiatry, surgeons, blah, 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 a lot of the downstream effect, I think. And then I take it a step further. I'm like, does that mean that all these doctors are then going to be forced now to be less interventionist and less procedure and more holistic and preventative, right? Because, you know, a lot of times people like doctors aren't holistic and preventative. Well, you know, when there's 1 million people coming into your office with 1 million problems, you don't have that luxury sometimes. If they're coming in and they need to have their foot amputated because they have diabetic neuropathy, blah, blah, blah. If they're coming in and they have severe cholestasis from obesity, well, that you're gonna take out the gallbladder. Like you could, you know, I'm a big holistic guy, but there's a threshold. And when grandma is jaundiced and icteric and she's obtunded, you're gonna want the guy to go in and fix that. Yeah. And I think as that stuff decreases, the final effect I wonder is what happens to the medical community. Like in medical school in 10 years, if our obesity rates drop, you know, 80% and all the downstream effect that comes from that, and cancers that, you know, colon cancer, so on, what's going to happen? Like, is there going to be a shift in specialties? Is primary care, which there's a shortage now, going to suddenly zoom up, right? Like, I think that's what I'm watching in the next 5 to 10 years. I don't know.
I would also be curious if they advanced surgical technique, you know, potentially for weight loss surgery, they come up with even better ideas that are not as invasive and more permanent versus, you know, the behavior changes, et cetera, we're talking about. So that might be another evolution that happens, that they come up with some different type of surgery that is less likely you're going to regain all the weight and you're not dependent on anything forever for maintenance. So maybe that type of evolution happens too.
And speaking of like the behavior stuff, my brother, he will, whenever he writes like the Manjaros or whatever, he will sit down. He says it more eloquently. I forget how he says it exactly. I don't know if you've been with him when he does it. Sarah knows, like where I'm bastardizing it, but it's basically like, all right, we're going to do this for, you know, 12 weeks or whatever. And during these 12 weeks, you're going to exercise this amount. You're going to change your diet. You're going to get rid of carbs. You're going to be blah, 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 blah. And with that, like as your lifestyle improves and your weight goes down medicinally, then in 12 weeks, we can get you off of this, or 18 weeks,
Yeah.
or however long. But now you're set, right?
Yep.
Like you've lost the 15 pounds. You want to lose 20. You've lost the 15. Now the last 5 you could do on your own. And he leaves that tail so that you do have to lose a little bit on
Sure.
your own because if you've changed your behavior,
You should.
you can lose that last 5 and then maintain. And so, the one thing, not to, I mean, we're harping on this just because it comes up so much.
Yeah.
I was talking to a doctor, an adult primary care, not my brother, a different outside our practice, and he made a comment when I was having this discussion with him. He said, yeah, but you know what? You don't necessarily have to have that conversation. I'm like, no, it seems like a sensible conversation. Why wouldn't you have it? He's like, well, think about how the medicine works. I'm like, okay, and he was logical. I'd be curious what you say. He goes, the medicine works by decreasing the appetite.
Yeah.
He's like, so you have someone who's been on this for 3, 4, 5 months,
Mhm.
and they've eaten less.
Mhm.
They've learned, deliberately or not, to consume less for 3, 4, 5 months for the first time in their adult life. So now that behavior has taken place. Like it's kind of, and I was like, that's a pretty interesting thing, right? Like, and that gets to the psychology of it all.
Yeah.
But I have seen a handful of parents that I'll see that, obese, see them like they come in like 6 months for like a physical for their 6-year-old, and they've lost like 40, 50 pounds. And I'm like, you look great.
Yeah.
Then they come in 6 months later and they've gained it all back. I have seen that.
Right.
Like it does happen.
So officially, the data there is actually we have 4-year studies out now for the Wegovy, which is one of the drugs that you continue losing weight for 12 more months after stopping the drug.
Okay.
But beyond that, we still don't have enough long-term data. But I agree with you. Even though the behavior changes while on the drug, I have plenty of patients who had to stop the drug for whatever reason, out of stock and whatever, and they were not able to control the urges, the
Yeah.
cravings. Even though they had been doing that, let's say for 6 months.
Yeah.
So generally, anecdotally, I have had more patients fail than continue to
Okay.
maintain the behavior change. And only time will tell. And that is why I think that counseling that happens in the very beginning is so essential.
Yeah.
Which your brother is doing, and I think all of us should try to do. So we're not relying on the chemical to just do it automatically. And the patient also feels good. I tell the patient, the low dose is not going to do so much for you. So I want to give them credit that some of the weight loss
Right.
is you.
Right.
It's you changing the behavior that we talked about.
Right.
And I just don't think that everything is happening because of the drug.
Right.
Some of it is you. Like you cannot lose 20 pounds in a month just on that medication. It was
Right.
like serious dietary changes that you made
Right.
because you listened and you got the counseling that you needed.
Yeah.
So they feel good.
Yeah.
And very important that we do not give credit entirely to the drug.
Right.
And if patients are doing something on their own, we acknowledge that and really champion that.
It's great.
Nice. Next question we have. Someone asked, it's a 2-part question. Can you explain the role of the thyroid gland and how it affects your overall health? And then what's the difference between hypothyroidism and hyperthyroidism?
All right, very, very, very valid question. Comes up a lot, in the community everywhere, actually. So first of all, thyroid hormone is a life essential hormone. We cannot live without thyroid hormone. It's very hard to be in a situation where you naturally just completely stop producing it, but it can happen. But more often than not, you completely stop producing it after neck surgery, neck radiation, something like that. But most of us, develop, mild hypothyroidism. The number one cause is, we don't know, idiopathic. It can also happen because of Hashimoto's. That's another term that goes up a lot with thyroid disease. Hashimoto's is a autoimmune condition, where your body's immune system is kind of slowly killing off your thyroid cells, and you reach a threshold where you have killed off enough thyroid cells that you become underactive. So thyroid hormone, just to explain what it does, it regulates your metabolism. So whether it's body temperature, bowel movements, weight, it regulates your menstrual cycles for women. It regulates your heart, how much your heart is beating. If you have severe thyroid dysfunction, you can develop heart disease. It can, bowel habits, in terms of constipation or diarrhea, cognition. Frequently, patients have, cognitive fogginess, and then I'm like, okay, we can check your thyroid, see if there's something going on there. So poor concentration, some memory issues, fatigue, that's the biggest thing, that we worry about, low energy, because you just kind of feel down, once you don't have it. Mood, you can get very depressed or anxious, depending on which version you have. And those are the big things. And, like palpitations, tremors can happen if you're a little bit off with that. And so hypo versus hyper. So I would say hypo is much more common. And I tell patients, hundreds of millions of people around the world are taking thyroid hormone replacement. So that is synthetic thyroid hormone because they don't make enough. The main symptoms of that are weight gain, sometimes hair loss, depressed mood, feeling unusually cold, constipated, irregular periods. Worst case scenario, you can go in a coma. If you just have zero thyroid hormone in your body. We see these probably once a month in a hospital on average. Hyperthyroidism, less common, but more dangerous, I think, in the acute setting, is where you have too much thyroid hormone, and that can cause, losing weight, palpitations, tremors, labile mood. All of a sudden you're yelling at your family members out of nowhere. Irregular periods can happen with that as well. Increased bone turnover, so it can cause you to develop early osteoporosis. So you have more bone breakdown, fracture risk, and arrhythmias. Atrial fibrillation, the most common thing we think about. The first test an ER or a cardiologist or primary care doctor would do is your thyroid levels to rule out hyperthyroidism. And hyperthyroidism, can happen in multiple different ways. The most common thing we think about is another autoimmune condition called Graves' disease. Your body is producing too much. Sometimes it can cause bulging eyes that people think about. Other second most common thing is a toxic nodule. So you have a nodule in the thyroid gland that is overproducing hormone. And then lastly, thyroid hormone can fluctuate just from a viral illness. So we never like to check the levels if we were recently hospitalized, you had a major, illness, viral illnesses, or IV contrast for a CAT scan. And that's the thyroiditis, which is just a temporary inflammation that kind of makes you hyper for a little bit. You're overproducing by leaking hormone. Then you kind of go into a rebound underactive phase. And then hopefully you level out and you're back to normal. But sometimes you stay underactive, hypothyroid for long term.
Yeah. And then in P, it's one of those things like, it's interesting. You have like type 1 diabetes, type 2 diabetes. And obviously these days, the lines are very blurry. We see type 2 diabetes in teenagers, which when I was in training, you never saw. It used to be automatically they presented in DKA. Now, like we catch it, but the presentations can be different in kids and adults. The thyroid, while it's more manageable, of course it could be severe, but it's generally a lot of adults are walking around with it.
Yeah.
Pediatric, again, when I came out, and that was one of the main reasons after PKU, that was like the second test for newborn genetic screening, because in the old days, you wouldn't know. Baby's born. Now the kid's 6 months old, failure to thrive, not hitting his milestones, whatever. And then at 9 months, 1 year, the kid, okay, let's just do a blood test. And by then, it's permanent brain damage and it's irreversible. It's pretty devastating. And that speaks to how, I think you correct me if I'm wrong, the thyroid hormone is the most involved hormone of anything in your body. It's involved, like, as you listed. I have a question. I think because we talked about PCOS, we talked about thyroid. What we are seeing now, what we see a lot of is just broadly speaking, hormonal therapy.
Sure.
So like 6-7 years ago, it was not common, like 6-7 years ago, to have a 28-year-old man, healthy, past medical of any significance, come in and be like, hey, check my testosterone.
Yeah.
Checks it and wants to be on testosterone replacement therapy. And now we have 5 a day that come in for that.
Yeah.
Easily.
Right? And to examine them or to take a history, it wouldn't even cross your mind. Maybe cross your mind. But, a lot of them, I don't want to say funny, but like they'll be like, my libido's off. I'm like, and then when you actually ask them, or like, hey, whatever, I'm losing muscle mass. Rather subjective, sometimes it's not, but a lot of times it is. And now, like the peptides and so on, can you comment, Dr. Agarwal, just in general on, because it's also one of those things where there aren't real great standards yet.
Sure.
So can you just give perspective and maybe just give background on that? And I'm asking for myself
Sure,
now
sure,
to be
sure.
better
And then
educated.
Can I also add another question, like on the same? There's now with the new, like my age, kids my age, a like rage of kids doing testosterone without seeing a doctor, without seeing. So can you just talk about the risks of that?
So, this is something I see a lot, actually, and I've actually had some of the members, come see me. And issue number one is, yes, they have, I don't recover from the gym
Right.
sufficiently enough.
Right.
That's one of the biggest things. Low libido is like not as much on the mind sometimes, or like fatigue is there sometimes. So the first thing I tell them is, let's verify that you really have a low testosterone. And this can be very challenging actually, because there are certain assays, lab assays, that are just not as accurate. And I've had multiple patients where I just repeated it on a more precise assay and it was normal. And then I just show it to them, okay, your total testosterone is normal, your free testosterone is normal, there is no abnormality.
Can you just clarify?
Yeah.
Do you mean if it's like a LabCorp versus Quest, or what do you mean exactly?
Within LabCorp, actually.
Yeah, okay.
So within LabCorp, we usually end up just doing this testosterone free and total. But there's a testosterone profile too, which takes into account.
That's the order? That's how it's
that
titled?
exactly, because I actually shared with one of our colleagues which one it is.
Oh, okay.
Testosterone profile 2, and that takes into account sex hormone binding globulin, which is the protein that the testosterone is bound to, and albumin. And it gives you a much more precise calculation for testosterone. So I start with that early morning, obviously. You have to make sure it's done early morning, not in the afternoon. So it has to be like a fasting before 9 a.m. So I start there. And then frequently, the other thing that happens is the patient has a low total testosterone, but a normal free or bioavailable testosterone. So I tell the patient that this is, again, a interpretation issue, because when you're overweight or obese, naturally, your sex hormone binding globulin is lower. So that range of total testosterone is assuming a normal sex hormone binding globulin. So if you have a low binding globulin, your total will be low, but your free is normal. Then I tell that patient that the issue is your BMI is above 30. And then the LabCorp assay actually says this is only valid for a BMI below 30. So I tell the patient, it's on the thing, I'm not just making this up, and your free levels are normal. So what I know is there is no endocrine pathological reason for you to have a low testosterone. Whenever I do these tests, I check their pituitary hormone as well, the FSH and LH, to figure out, what's going on with signaling, find out about any genital trauma, head trauma, any biological children, to rule out any kind of like chromosomal abnormality. Very rare things, just to make sure there's not a testicular issue. And then if I have, and I check thyroid hormone, another hormone called prolactin, if there's interference going on. But once I have established a truly low testosterone, I like to talk to the patient, what is the etiology? Because once I start testosterone therapy, it's impossible for me to backtrack and come up with what caused this in the first place. Because when you start any exogenous hormone, whether it's testosterone, whether it's cortisol, even thyroid, your endogenous kind of shuts down.
Right.
So then you have this miserable 6 to 12 months where I'm going to ask the patient, I got to wash everything out so I can really verify what you have, why you have it. And that's not an easy conversation, right? So I thank you for not having started anything. Just give me a couple more weeks. And the biggest test as an endocrinologist that I have to do is ruling out a pituitary adenoma, right? That's, something that we do not want to miss, because if you have a tumor in the pituitary gland, it's right behind your eyes, not like inside your head. That can cause suppression of all of your hormones. And then we have to go take it out, address it surgically, and then things should get better. Other things that can cause this are HIV drugs. So I've seen a lot of patients with HIV drugs. I've done all the workup, including an MRI. Then I'm like, okay, it's real. You're on HIV drugs. That's the answer. Chronic opioid use or opioid dependence, even like, methadone maintenance programs, et cetera. So, chronic opioids, narcotics kind of suppress, a lot of your hormones. Ferritin, hemochromatosis, if you have iron overload or some weird infection in that area, that can cause this. So I just like to rule out, those 4 or 5 common things. And then after that, if it really is low, I talk about, what is your reproductive plans? If you're a young man, are you looking to have children? If you are, then I'm a little bit wary about putting you on testosterone, because that will reduce your sperm count, sperm quality, and then it's going to be harder to make a woman pregnant. And then you have a different type of therapy where you're increasing the signaling from the brain. It's called HCG injections, et cetera. But that's an important conversation to have, so you're not missing anything, down the road. And then if I do have to start testosterone, we do it, injections versus gel, those are the most common things. And very rarely patches I use. But I guess the other gist of your question was like, why is this happening more? I think it might be more awareness, more than anything. I think in the last decade, there were the testosterone trials came out. Those were more for older patients. But I think everybody is just a little bit more aware, and everybody knows it's like a simple blood test. I can go get it, and then have the conversation. Then there's not as much stigma around replacement. It is a controlled substance, testosterone, but it's okay. If somebody needs it, they need it. I cannot think of any major, there's always a concern about environmental changes, chemical changes that are happening generally in healthcare that patients are getting exposed to, causing early low testosterone. But that's how I approach it. Really pin down the diagnosis. And I'll be honest, 90% of the patients I've seen for low testosterone did not have low testosterone.
Right.
And the patients were okay. And I was like, okay, you want to help lose weight? Let me help you with some obesity management, and that will naturally improve everything.
Okay.
And the patients are reasonable, actually. My fear as an endocrinologist always was, patients are going to fight with me to give them testosterone. I'm like, I'm denying it or something.
Yeah.
But I know they don't need it.
Yeah.
Even in the VA hospital, when I did my training, at the vets, which have, good reasons to have low T, but everybody is very reasonable if you spend the time talking to them about what's going on and explaining everything.
Yeah. If you decide someone needs testosterone, it's the injections are weekly, or are they at home in the office?
So they're home. I try to do it at home. Maybe one or two just to teach you, but I like it to be self-administered. I think injections have been more effective. I'll be honest, in my experience. Androgel, the gel formulations are all over the place, and there's also a lot of insurance coverage issues with them, different brand names, etc. With the injection, depending on how the patient is feeling. So I have mostly started weekly, so there's less of a peak and a trough, so I don't have to worry about it too much. Okay. So instead of that double dose, which I might give every 2 weeks, I give the half dose every week. So the total cumulative dose is not that high, but I think it's more steady state, for the patient versus, every 10 to 14 days.
And then the last question I have on this: when should a primary care doctor, or when should the average patient contemplate this? What you like, the way you listed off, with thyroid dysfunction. Yeah. What are the things, if you're a male, should make you start that conversation?
Sure. So number one thing should be if you truly have low libido. So erectile function is more of a blood flow issue. It's a vascular issue. I tell the patients, even if I give you as much testosterone as you wanted, it might not fix that. And you might still need Viagra or Cialis or something to control, erectile function. But if it's truly, debilitating, fatigue, weakness, and low libido, which is controlled by the hormone, then yes, that's a real thing. Right. The muscle in the gym, etc., hit or miss. I am not in a hair loss, hit or miss. It truly, clinical reason to do it is if somebody is having early fractures. So osteoporosis. So if somebody healthy, a guy, broke a bone at age 30, I'm like, what are the secondary reasons? Why are you breaking a bone at age 30? And like a woman who, if she had early menopause, low estrogen, gets early osteoporosis, which we often neglect screening even in men. But if a young man or even a middle-aged man is developing fractures, do you have low testosterone? Okay. Because then I want to fix the underlying issue, which will naturally help your bones before I just commit you to osteoporosis drugs. So that, and I tell the patients when I'm starting it, it's not just your clinical symptoms. I'm worried about your bone health. Right. I don't want you having fractures and all the comorbidities and bad circumstances related to rehab and fractures in general.
Okay, that's great. That's very useful.
That's all I have.
That was
the
last
excellent question. That was excellent. I learned a lot.
Benefited a lot. I appreciate you taking the time.
No, I appreciate it.
Thanks.
Awesome.